Hi dear friends, today's topic of discussion is going to be indication and initiation of mechanical ventilation in pediatric age group. So basically there are three major needs for a mechanical support in ventilation. So they can broadly be classified as a problem in oxygenation. Oxygenation means increasing the arterial oxygen concentration. A problem in ventilation. Ventilation means exhaling out or pushing out the carbon dioxide from the blood or for airway protection. Whatever may be the cause, if it is going to hit the patient too hard or too fast, it is going to result in respiratory failure, which can be hypercapnic, which means too much of carbon dioxide in blood, or hypoxemic, which means very less oxygen in blood. The mechanisms of respiratory failure again can be broadly thought of in these terms. If you think of how the lungs actually exchange gases and help in taking part your oxygenation and ventilation, then you can get this idea. Suppose there is a problem in the brain giving out responses, then the patient can have a respiratory failure, or if brain is working well, but the problem is in the anterior horn cell, or the problem is not there. The problem is in the nerve that goes to the muscles of respiration, or if that is also doing fine, there is a problem in the neuromuscular junction where the nerve ends in the muscles. Suppose neuromuscular junction is also working well, then the problem might be in the muscles. Suppose all this apparatus is working well, brain is sending out signals, your anterior horn cell recognizes it, then the anterior horn cell sends signals through the nerve, then the nerve ends in the neuromuscular junction and it helps the muscle contract. Even if all of these are working well, if there is a problem in the airway, then again patient can have respiratory failure because it is not going to allow air to get in or get out. Or if airway is also doing fine, then the problem can be in the actual gas exchange unit, which is the alveoli. Or if alveoli is also fine, then what stays in between the blood vessel and the alveoli, that is the alveolar capillary membrane, isn't it? So you have some amount of interstitium here, you have some amount of extra XYZ there. So all of them put together will form your alveolar capillary membrane. So if there is a problem in the membrane here, then again there can be a problem in oxygenation and ventilation. Correct? So all of these can put the patient into a respiratory failure ultimately. So you have this alveolar gas exchange equation, which we have been seeing from beginning, not just beginning of our lectures. You have been reading this from your MBBS days, your physiology days, right? Your alveolar partial pressure of oxygen is equal to inspired oxygen partial pressure minus your alveolar carbon dioxide. Whenever you have a capital A, it means alveolar, small a means arterial, divided by respiratory constant. So your inspired oxygen partial pressure, you will have to think about it like this. Your concentration is 21%. Yes, all of us know it in your atmosphere air. What's the atmospheric pressure? So here you are talking in terms of pressure, right? So atmospheric pressure is 760 millimeter of mercury, right? So 760 is your atmospheric pressure. So is oxygen concentration 21% of 760? No, because you have some amount of water vapor. So that accounts for approximately 47. So if you subtract 760 minus 47, that will be your atmospheric pressure minus your water vapor pressure. From that, 21% is your room air partial pressure of oxygen. In ventilation parlance, your PiO2 can be your FiO2, okay. So, or in other words, this will be your FiO2 if you have set it at 40% or if you have set it at 60%, right. If you have set it at 100%, then it is just 760 minus 47, right. This will become into 1. I hope you are getting what I am trying to tell. So, why am I bringing this equation here? Suppose you are not giving the patient enough oxygen. Okay. So, if not enough oxygen is there in the atmosphere, less oxygen is going to go into the alveoli and less oxygen is there for exchange. So where are the conditions in which you will have less inspired oxygen concentration? Either you are setting the FiO2 very low, or the patient's atmosphere per se has very low FiO2, like in higher altitudes. Next, you have enough oxygen and air, but alveoli is not in a situation to accept that extra air, or it's not in a situation to push that into your blood. There might be too much carbon dioxide in the alveoli, that is displacing your oxygen. Or if alveoli is doing well, your oxygen concentration is okay. What about diffusion? You have the alveoli and you have the blood vessel. Let's put our alveoli in some other color. Okay. So you have your alveoli and you have your blood vessel, right? This is your blood vessel, this is your alveoli. Suppose you have something else in here that is inhibiting the gas exchange, inhibiting the diffusion of gases. So what are the factors that determines the gas exchange? So this gas diffusion depends, or it is directly proportional to the area of diffusion and the difference in partial pressure. So alveoli has increased oxygen concentration compared to that of blood. That's why oxygen goes into blood. Your blood has too much carbon dioxide concentration compared to alveoli. That's why it goes into alveoli, isn't it so? So difference in partial pressure is also important. And your gas diffusion is inversely proportional to that of the thickness of alveolar capillary membrane. If the membrane here is too thick, then again you will have problems in gas exchange. This diffusion defect usually affects oxygen more than carbon dioxide, because carbon dioxide is a more easily diffusible gas. Suppose there is no problem in air entering, there is no problem in the alveoli, there is no problem in the capillary membrane, then even then you can have something called as ventilation perfusion mismatch. So this is a blood vessel, this is the normal alveoli. So you have oxygen entering here into the blood vessel, and you have carbon dioxide in the blood vessel going out into the alveoli, right? And blood travels in this direction. So imagine the situation where the alveoli here is filled up with oxygen and it's waiting for the blood vessel to bring in the blood so that it can exchange this oxygen for carbon dioxide. But no blood comes because there is a block. So what happens? During inhalation oxygen comes in, and during exhalation the same thing goes out. Nothing gets exchanged here. So this sort of forms a dead space. Alright, so this becomes a dead space ventilation, pathological dead space. Another situation where you have blood vessel waiting with carbon dioxide for the alveoli to come in or fill with blood, but this alveoli has collapsed. So as a result, this your blood vessel, which is filled with carbon dioxide rich blood, enters, no gas exchange is happening, it exits out with the same amount of carbon dioxide. So this essentially functions as a shunt. Okay, this is just passing through with nothing happening here. So this is a ventilation perfusion mismatch scenario. So if you put all of these together as cause for respiratory failure, you can just say one indication of mechanical ventilation, which is respiratory failure, right? So, yeah, apart from that, to reduce work of breathing, you need to ventilate the patient. What do you mean by reduce work of breathing? See, only in conditions where the respiratory drive is depressed, the patient is not going to make an effort at all. But otherwise, in other conditions where there is oxygenation defect or a perfusion defect or your ventilation defect rather, the patient is going to work hard to bridge the mismatch, right? So initially there will be too much work of breathing, then the patient fatigues out, the respiratory muscles fatigue out, and ultimately the patient can stop breathing. So you don't want the patient to go to that level, so you take up some of the workload or work of breathing from the patient's end to the ventilator end. There can be increased demand, as in case of metabolic acidosis, shock, neuromuscular weakness we discussed, alveolar hypoventilation we discussed, hypoxemia, all the causes we discussed, and for airway protection. If the patient is going to not have enough central responses, then the patient can aspirate his or her own secretions, right? So for that sake, you need to place a tube to protect the airway. In reality, you cannot actually segregate as saying this is purely a hypoxemic problem, this is purely a hypercapnic problem. Usually it's a combination of multiple indications for mechanical ventilation. So ultimately you are trying to reduce the work of breathing of the patient and improve oxygenation and ventilation so that patient has a better homeostasis. So what are the initial settings that you want to choose? So I will be discussing the individual settings on your ventilator. I will not say in extensive detail, but the basics of it and what you need to know. So what is tidal volume? Tidal volume is the amount of gas that is delivered with each breath. Okay, it can vary from 5 to 10 ml per kg of ideal body weight in pediatric age group. This looks like a wide range, when in reality probably the normal adolescent or an older child may breathe anywhere from 8 to 10 ml per kilos. Whereas a child who is having a restrictive problem or a ARDS like situation, so ventilating them with this much amount of volume will actually cause injury. So ventilate the people with restrictive disorders with lower volume, say around 6 ml per kilos. Okay, 6 to 7 or 6 to 8 ml per kilo. So that's a lung protective strategy, low tidal volume ventilation. In patients with asthma who are having a obstructive disorder, you need to have higher volume to try to overcome the resistance of the airways. So that's about tidal volume. Tidal volume is a determinant of ventilation. Okay, so tidal volume is going to determine how much carbon dioxide is going to get out of the body. Okay, the inspiratory tidal volume ideally should be equal to that of the expiratory tidal volume. Now I will tell why it's a determinant of ventilation in a moment. Okay, I want to discuss respiratory rate before getting into your explanation about ventilation. So inspired tidal volume, this is the inspiratory tubing, should be equal to that of your expired tidal volume. Suppose the tidal volume during inspiration is more. So in between there is some amount of air that is lost, right? So you must suspect a tube leak or a circuit leak. Usually you should account for the circuit compliance because the tubings also can hold some amount of air, but most of the times the ventilator account for that amount of air. So that won't be an issue. So generally if you see huge variation between your inspired and your expired tidal volume, think that there must be some loss of air somewhere in the circuit. So this is about your tidal volume setting. What about your respiratory rate? Respiratory rate depends on the age of the child. The younger the child, more the respiratory rate. For example, in a neonate it can be around 40 breaths, 40 to 50 breaths also sometimes. In an infant or a younger child, it can be anywhere from 20 to 40 breaths, and in older kids 15 to 25 breaths per minute. And it's usually a combination of mechanical breaths and spontaneous breaths, and if you are going to give only pure pressure support ventilation, it will be pure spontaneous, but in reality it's usually ventilator breaths and spontaneous breaths together. Since we are discussing respiratory rate, I think it's important to touch upon time constant once again. This was also asked by one of the students. So time constant is the time taken for alveolar pressure to equalize to that of the airway pressure. Okay, so it can be during inspiration or expiration. Alright, both are called as time constant. So what your time constant is classified, or it's calculated as your compliance into resistance. One time constant means 63%, two time constants is 86%, three time constant is 95%. So if you give this much amount of time, then you have 63% of pressure being equalized between your airway and your alveoli. So it needs 5 time constant to approximately equalize 99%. So in other words, your time constant will be your determinant of inspiratory time. Why not expiratory time? See, theoretically speaking, 5 time constants for inspirations means 5 time constants for expiration also. No, 99% fills, 99% goes out. So air pressure equalizes. But in reality it does not happen that way, because during inspiration, or at least a spontaneous inspiration, there is a negative intrathoracic pressure which causes the airway diameter or radius to increase. So, more diameter, easy laminar flow. If the patient is going to exhale out, then the intrathoracic pressure increases, the airway radius decreases. This can result in turbulent flow. So, during expiration, for the air to go out of this smaller radii airway, it requires more time. That is why your expiration time is more compared to that of your inspiration time. Alright. So, this is what we discussed earlier also. If you remember in one of our beginning classes, basics of ventilation part 1 or part 2, I am not sure which, I think it is part 1. We discussed this concept of time constant in relation to compliance and resistance. So, I will just touch upon it once again. So, time constant is compliance into resistance, or in other words your Ti. So, let us keep it as Ti, 5 time constants is 1 Ti, 1 inspiratory time, isn't it? So, that is what your calculation is going to be. So, any condition that increases the resistance is going to increase the time constant, correct? Because these are all directly proportional. Any condition that decreases the compliance is going to decrease the time constant. So, if you want to put it into an example, you have this alveoli which is normal and you have the airway which is very narrow. Okay, so more time will be required to fill this and exhale out, correct? So, you will need increased time constant or increased time, especially during exhalation. That is why when you have a disorder like asthma, you increase the exhalation time so that all air goes out. Imagine this condition where the airways are okay, but the alveoli are collapsed very much. Okay. So, why is the inspiratory time very less or the time constant less? So, imagine this alveoli which is normal. Imagine this alveoli which is stiff. So, here you have air entering in. Okay, this alveoli expands, it fills out with air at say 20 pip, just an example. Okay. So, 20 inspiratory pressure, it fills with 50 ml of volume, again all theoretical. So, this is an alveoli which needs to be filled with 50 ml. Okay. If it has to be filled with 50 ml, since this alveoli is very stiff, the pressure has to go very much up. Agreed with me? Only if there is increased pressure, then this small alveoli will distend to some extent so that it can accommodate 50 ml. Suppose you do not bring this pressure into equation at all. You just want to see how long it takes for this and this alveoli to fill. So, that is where your time constant comes in. So, you have again this normal alveoli, you have this small alveoli. Okay. So, to fill this alveoli, it takes approximately 20 seconds, assume. Here you have a stiff alveoli which is not going to expand much and smaller volume also. So, this will take maybe just 10 seconds to fill out the volume that is shown by the stiff alveoli. So, that is why your time constant is very less in conditions where there are lesser compliance, and lesser compliance example is your ARDS. That is why you go for smaller inspiratory time in conditions like ARDS. I hope this is better understandable. So, Ti and Te, inspiratory time and your expiratory time. Normal ratio is 1:2. We discussed why expiratory time is more. The normal inspiratory time that you set is dependent upon the age of the child and the weight of the child. 0.4 to 0.7 seconds in infants, 0.7 to 0.9 seconds in children, and 0.9 to 1.2 seconds in adolescents. Try to maintain a ratio of 1:2 to 1:3. You might need to increase your inspiratory time in your ARDS if you want better oxygenation. Okay. So, initially you start out with a smaller Ti, you might need to increase it if you need a better oxygenation. In asthma, you need to increase your expiratory time so that all your carbon dioxide has time to go out without allowing for auto PWP or air trapping. So, your tidal volume and your respiratory rate put together will form your minute ventilation, right. Minute ventilation is calculated as tidal volume into respiratory rate, but you are not interested in total minute ventilation, you are more interested in alveolar minute ventilation. Alveolar minute ventilation is tidal volume minus anatomical dead space. Your tidal volume normal in children is around 8 ml per kilos. Anatomical dead space stands somewhere at 2 ml per kilos into your respiratory rate. Your carbon dioxide concentration, on the other hand, is dependent upon carbon dioxide production in blood divided by alveolar ventilation. I am sorry, I am losing the letters here, right. If you do not want to take this carbon dioxide production into account, you can just say your arterial carbon dioxide concentration is inversely proportional to that of alveolar ventilation, which is calculated as alveolar tidal volume into respiratory rate. So, that is why your PaCO2, which in other terms you can call as ventilation, is dependent on inversely proportional to your alveolar tidal volume and your respiratory rate. Got my point? That is why your tidal volume and respiratory rate are determinants of ventilation. Next, coming to FiO2, which is fraction of inspired oxygen. Again, it depends on patient's requirements. You need to have a target saturation SpO2. Say for healthy lungs, you can keep it at about 94%, or in diseased lungs, it can be lower, 88 to 92%. Target PaO2 can be as low as 55 millimeter of mercury. You have to keep in mind your arterial oxygen concentration is approximately 5 times that of inspired oxygen concentration. And permissive hypoxemia is definitely acceptable in cases of conditions like again ARDS, which I think we will be discussing more in detail when we are discussing disease specific ventilation. And you need to titrate to maintain the lowest inspired oxygen concentration to achieve the target SpO2 and target PaO2. You may start at 100% depending upon the patient's condition, but titrate it down fast so that you achieve the lowest possible level in order to not cause oxygen induced injury to the patient. So, this is PIP, peak inspiratory pressure. So, PIP is the maximal airway pressure that is reached during a delivered breath, isn't it so? You know the waveforms, I do not think I have to teach it again. So, I will just directly go into talking about the waveforms. So, this is like a standard pressure wave, correct? So, this part is your PWP, end expiratory pressure. This is your PIP, am I right? So, this part above the PWP is called as delta pressure. So, PWP plus delta pressure together will result in your peak inspiratory pressure. You choosing your peak inspiratory pressure again will depend on your underlying lung pathology. So, normal is somewhere between 18 to 25 centimeter of water, and you can choose higher end if the patient is having a more pathological lung, a normal range if the patient is having a normal lung but the problem is in the respiratory tract, but try to avoid very high PIP to avoid barotrauma to the patient. Next, PWP, peak end expiratory pressure. This is the airway pressure at the end of expiration, isn't it? So, you do not want the lungs to or the alveoli to collapse at the end of expiration. This maintains your functional residual capacity. Normal is around 3 to 5, I can say, it is not 5 to 8, it is 3 to 5 centimeter of water. Okay. Higher PWP is preferred in ARDS and lower PWP in asthma. Why lower PWP or end expiratory pressure in asthma? Because patient per se has air trapping, isn't it so? So, you have a patient who is having a reduced airway radius. The patient is trying to exhale out. Okay, suppose not much expiratory time is given, expiration is cut off. Okay, if you want to put the same in a graphical format. So, this is a, let us say, a volume controlled mode of ventilation. So, this is how the patient is starting out. Okay. So, the patient is starting out something like this. Okay. So, this is during inspiratory hold, normal one, patient with asthma will look something like this, because the P peak and the P plateau will have a lot of difference, because the parenchyma is normal, your plateau pressure will be normal. Since resistance is more, your peak pressure will be high. So the base should touch your PWP, or it should come back to PWP. If the patient is not allowed to exhale completely, then some amount of air is still going to remain inside the patient, resulting in elevation of this baseline. Okay, and this goes on increasing, Similarly, your flow also, your flow is supposed to touch the baseline, isn't it so? So your flow rate is supposed to come back and touch the baseline. But what happens here? You have your inspiratory flow, you have your expiratory flow. This is supposed to touch the baseline, but here in this patient, since there is already air that is trapped inside, it starts somewhat like this. Okay, since there is already PWP inside, air trapping inside, you do not want to add to the end expiratory pressure, so you start at lower PWP in a patient with asthma or any condition that can cause an air trapping. What about pressure support? Suppose you are having a SIMV with a pressure support mode. That's the amount of support you are going to provide to the spontaneous breath of the patient, right? It depends on the effectiveness of the respiratory effort and your endotracheal tube diameter of the patient. Usually it's somewhere between 5 to 10 centimeter of water. So all that we discussed now, pressures, your FiO2 or your inspiratory time specifically, all of them are determinants of oxygenation. Why do I say oxygenation? Because oxygenation is determined by two parameters basically, your inspired oxygen concentration and your mean airway pressure. Okay, what is your mean airway pressure? Again, this can be explained by mean of your graphics. If you have not listened to graphics, you will not be able to understand these. So please go ahead, revise your graphics so that you can understand the waveforms that we are drawing. So this, for example, is your pressure waveform, pressure time scalar. Okay. So what is your mean airway pressure? Mean airway pressure is your area under this curve. Okay, so from here till here, whatever area is there, all of them will come under your mean airway pressure. This is your PIP, this is your inspiratory time, this is your PWP, and this is your expiratory time. Okay, so all of this together is your TI plus TE, and all the area under this curve will come under your mean airway pressure. Okay, what are the things you can do to increase your mean airway pressure? So let's see here. Suppose you want to increase your mean airway pressure, you can increase your PWP, correct? So that will increase the area here, am I right? Or you can increase your PIP, that is again going to increase your area, or you can increase your inspiratory time, that is again going to increase your MAP, correct? So these are all some of the examples by which you can improve the oxygenation of the patient. You can increase flow, you can increase PIP, you can increase PWP, you can increase inspiratory time. Okay, increasing TE is not a very effective way to increase your MAP. It's going to be very negligible. So that's why we are not discussing your expiratory time. Always remember, percentage change in your FiO2 will definitely change your PaO2. By how much? 1% change in FiO2 can result in 7 mm of mercury increase in your PaO2. Similarly, a decrease in FiO2 will cause decrease in PaO2 also, or approximately 5 times you can remember. So this is alveolar concentration, 5 times is your arterial concentration. 10 mm of decrease in your alveolar carbon dioxide will result in 10 mm mercury increase in your alveolar oxygen concentration. The normal requirements for ventilation, other settings that you do generally is trigger setting, your flow rate, your cycling. So all of these again depends on which ventilator that you use. Each one is different, each one has its own namings, the color coding is different. So I will not be able to touch upon each and every ventilator model that's there. But overall what you can remember is flow trigger you can set at 0.4 to 1 liter per minute for younger kids and 0.8 to 2 liter per minute for adolescents, whereas the pressure trigger threshold is normally set at -1 centimeter of water. Your flow rate can be set or calculated depending upon the mode. Cycling, again, if it is time based cycling, it's based upon your respiratory rate. Suppose you set respiratory rate at 60 per minute, correct? Right, 60 per minute, then it's 1 breath per second, and every second the ventilator is going to complete the breath cycle, correct? And in that 1 second your inspiratory and expiratory time will vary. Flow cycling is generally part of your pressure support ventilation. At the end of 25% of your peak inspiratory flow, it cycles back into expiration. This is just a consolidation of what we discussed so far. A pressure controlled mode of ventilation is preferred by many intensivists and pediatricians. Depending upon the age of the child, you can set your PIP at 16 to 25, PWP at somewhere between 3 to 5 or 3 to 7, depending upon the underlying condition. Rates will change depending upon age. Rates will decrease as the age advances, and inspiratory time will increase as the age advances. Pressure support, again, it depends on, as I said, your endotracheal tube size and your patient's breathing efforts. Suppose the endotracheal tube size is somewhere between 3 to 3.5, then maybe your pressure support can be around 10 centimeter of water. If the tube size is more, then not much resistance will be there, so your pressure support can be reduced to 8 centimeter of water. If the tube size is more than 5, then it can be 6 centimeter of water. This is just a thumb rule, and again you will increase or decrease depending upon your patient. Okay, so all of what we discussed are just to give you an idea to start out maybe. Then the later adjustments will depend upon how the patient is improving or deteriorating. So this is about your pressure controlled ventilation. Your volume controlled ventilation, again you are going to set your flow and your tidal volume around, depending upon the age, depending upon the lung status, 5 to 8 ml per kg if the infant is healthy, 3 to 6 ml per kg if the patient is having ARDS like presentation. PWP is somewhere between 3 to 8, pressure support 6 to 10, again depends on your endotracheal tube size. Inspiratory flow will be adjusted to fit the desired inspiratory time. Okay, I think maybe we will discuss this in tomorrow's class, your dysynchrony and synchrony. Yes, I think that will be better. And your inspiratory time increases as the age increases. FiO2 you will start at some point but then rapidly wean so that your target SpO2 and PaO2 are maintained. Flow trigger 0.25 to 0.5 in young child, and higher triggers can be kept for older children. I think that's it about your indications and initiation of ventilation. Thank you guys for listening to me patiently. Hope this made some sense to you. I hope I am making myself clear. It's difficult to teach some audience that I am not visually seeing, to understand whether you are grasping the concepts or not. So if you have any doubts, please feel free to let me know. I will try to clear it as much as possible. Share this with your friends, colleagues and juniors if you found this useful. Thank you guys.